Good afternoon and welcome. I'm Wynn Kane, President of the League of Women Voters of Lake Forest, Lake Bluff area. And the League is pleased to be able to provide this program, Your Child's Health, the Impact of Climate Change, Healthcare, and Gun Violence, and Gun Safety. We are delighted you could join us for this important discussion. We're delighted to have you all with us. The League is a national nonprofit, nonpartisan organization. We do not endorse or support any political parties or candidates. We work at the national, state, and local levels to increase understanding of major public policy issues and to influence public policy through education and advocacy. Membership is open to both men and women. We offer a variety of activities throughout the year: voter registration, candidate debates, public programs, and discussion groups. If you're interested in public policy issues or being engaged in the political policy, please think about joining us. We'd love to have you. Membership brochures are available today, or go to our website and follow us on Facebook. Today's program is being videotaped, recorded by Lake Forest TV, and will be shown on Channel 17 or 19, our website, and YouTube. At this time, I'd like to introduce our moderator for this afternoon's program, Dr. Stephen Potzik, who will introduce our speaker. Dr. Potzik, currently serving as our League's treasurer, is an Illinois licensed physician with a master's degree from the University of Michigan, is clinically trained in pediatrics, and is board certified in preventive medicine. Dr. Potzik served as the Regional Health Administrator for the U.S. Department of Health and Human Services. He was Principal U.S. Public Health Service Official in Region 5, represented the Assistant Secretary for Health and the Surgeon General on matters of health and science, was in charge of the federal public health programs, including emergency planning, response, and bioterrorism, and had top-level security clearance. In that role, he also was involved in the Affordable Care Act, about which he had given numerous factual policy presentations. It's my pleasure to welcome today's moderator, Dr. Stephen Potzik.
Thank you, Wynn. I'm pleased to be here today. I wanted to speak a little bit about the League of Women Voters, some things that I've heard in the past. Many people who have heard of the League of Women Voters know about our voter services, registration of voters, candidate debates, poll watching. But sometimes I get the comment about not quite sure if we're nonpartisan. And the reason I get that question is because we do have policy positions. And in fact, 3 of the policy positions will be discussed with the American Academy of Pediatrics today. Why they sometimes say we're aligned with a political party is because some of these policy positions are exactly the same or very close to the same of a particular party. But I wanted to assure people that, in fact, our policies are created independent of any other organization. There is a very significant research of the topic. A position paper is drawn up, and there is a consensus process. So sometimes we can be accused of being part of a political party because of a certain position, and sometimes a different political party. But I just want to make it clear to people that the League of Women Voters is in fact nonpartisan, but we do have very specific policy positions that we take a strong advocacy role in. And our website, both our website, the national website, the Illinois website, have really good synopsis of what those policy positions are. So if you'd like to see, besides voter services, what else is the League involved with, I would suggest that you look at one of those websites. Now I want to go over a little bit about the format for today. As you know by the title, there are 3 different policy issues that are going to be discussed. We're going to take one separately, healthcare first, for about a 20-minute presentation by our speaker. And then we're going to have about a 15-minute conversation of your questions that I will address to the speaker. And then we will go on to our next session. So we will follow that throughout this afternoon. I do want to make sure that you understand that we do not take questions from the audience. We only take questions that you write down on a card. And people are going out now and giving cards out. And so please write your questions. You can write them at any time, but they will be collected in time for the question and answer period after each session. It's now my privilege to introduce our speaker for today. When we look at the positions of the league on these three areas, we look to see, well, what other organizations, what other credible organizations have similar policies? And clearly, based upon a long history with the American Academy of Pediatrics, which was formed in about 1930, as I recall, we saw that the league's positions were very much aligned with the American Academy of Pediatric positions. And so I'm very pleased today to have this partnership for the league, have this partnership with the American Academy of Pediatrics, and have one of its vice presidents, Dr. Lynn Edwards, here today. So Dr. Edwards is the Senior Vice President, Primary Care and Subspecialty Pediatrics at the American Academy of Pediatrics. Prior to assuming this position in 2017, she was co-chair of the Children's Health Initiative at Health Partners, which is the largest nonprofit consumer-governed healthcare organization in the entire nation, as well as chair of pediatrics at the Park Nicollet Health Services, where she practiced inpatient and ambulatory general pediatrics, and she served an urban immigrant community. Additionally, Dr. Edwards was a member of the board of directors for the Institute of Clinical Systems Improvement and continues as a member of the board of the St. David Center for Child and Family Development. She previously has served on the American Academy of Pediatrics Vision of Pediatrics 2010 Task Force and as chair of the AAP Committee on State Governmental Affairs. She most recently co-chaired the American Academy Task Force on Pediatric Practice Change and served as the Academy's District 6 Vice President. Dr. Edwards comes from us from Minnesota, and she has served on numerous Minnesota state initiatives, including the Medical Home Advisory Committee, the Payment Reform Working Group for the legislature, the Minnesota Kids Integrated Depression System Advisory Committee, and co-founded the Minnesota Child Health Improvement Partnership. She participated as a member of the National Center of Excellence for Quality Measurement, which is a well-known quality measurement group that's based out of the University of Washington. She also was the past president of the Minnesota chapter of the American Academy of Pediatrics and served as the chapter's policy committee chair. Her areas of interest include health care transformation, child advocacy, quality improvement, health disparities, and cultural effectiveness in healthcare. Dr. Edwards received her medical degree and completed her pediatric residency at the University of Minnesota, Gophers, where she continues to maintain an adjunct faculty position. She has received numerous awards, many more than I could state today, but included the 2015 Homer Ventures Award for Excellence in Clinical Education and the Blanton Blessington Child Health Advocacy Award. Please give a round of applause and a warm welcome for Dr. Edwards.
Well, thank you for that. Indeed, I moved to the greater Chicago area about 3 months ago, and spring is here, right? This is spring-like weather in Minnesota. but am enjoying my time here, and but you'll notice the Minnesota accent as we go through. I actually, as I got this invitation, it brought back fond memories. I grew up, which is not in my bio, which that's a very lengthy introduction, is the fact that my family was very much engaged in the community and very politically active. My father caucused in his political party. My mother spent a lot of her time with the League of Women Voters. So early on, I had memories of election day where she would go off and work with voter registration while I would stay home with my father and watch the election results roll in. So this feels a little bit like I'm coming back to my roots in a certain sense. So Steve started talking a little bit about the American Academy of Pediatrics. And this is really a lengthy slide with a lot of words, but importantly, the American Academy of Pediatrics arose not as an organization for pediatricians. So I come to you today, yes, as part of an organization of 66,000 pediatricians and pediatric subspecialists, all dedicated to the health and well-being of children. That's our core mission. We believe that children are the most enduring legacy we have, and everything we do is based on what can improve the health and well-being of children. We have an agenda for children. Well, some of the issues we'll talk about today are different than what is in our core center. It really, you can see, is all around health equity, medical home, and surrounding what we would say are core key values of currently poverty and child health and early brain development, and actually all of that relates to those issues of healthcare, climate change, and gun safety. So we'll start with healthcare today. And I struggled with this because healthcare is actually a tiny element of health. And when we think about health, actually what I do in my clinic is perhaps only 20% of what creates optimal child health or optimal health for anyone. So health is actually much more than what we do in clinics or hospitals. It's really about where we live, the opportunities for us to enjoy access to education, clean water, safe homes, and that really creates the full health and well-being of who we are. This is one of my favorite quotes, and it really gets down to the core of pediatrics. I sense that Frederick Douglass really knew what it was to be a pediatrician. Not that he was a pediatrician, of course, but this is why we do what we do if you're in pediatrics. It is easier to build strong children than to repair broken men. What the research has really shown over the years is that our health in adulthood is really embedded to our early life experiences. What does that mean? Well, it doesn't mean that we're destined to always, if we have a slower start or a poor start, we're going to end up in a bad place. But the better start we have, the more likely we are to end up with optimal health as we achieve adulthood. Essentially, in pediatrics, what we want to do is not attain or maintain health, but we're actually helping our children attain and reach that optimal health and well-being so they can contribute fully in their adult lives. We know that most of brain development occurs within the first 5 years of life. In fact, 90% of our brains developed in the first 5 years of life. And that means that things like reading, talking, singing, playing with children matter a lot. It matters so much that children who are read to and have those interactions have as many as 30 million words, or spoken words to them in the first 5 years of life. Now imagine your success you will have as you start out in school if you actually have that many more words. What we know is the more successful you are in school, the more likely you are to graduate from high school. In fact, if you are not reading at grade level by grade 3 or age 8, you are 4 times less likely to graduate from high school. And if you don't graduate from high school, you're much more likely to be encumbered by chronic diseases, whether it be diabetes, depression, heart disease. You're much less likely to find sustained employment, and your economic and health and well-being takes a very different course. So it all starts in those first 3 years. And this is really why I'm here today, to say, how do we create a system, and how are we all engaged in trying to make a difference for our children? So it really is a system. I put this long timeline in here to kind of remind us that this is a journey. There's lots of discussion about our healthcare system today. Is it broken, and what's working or what's not working? But this is a timeline, so to speak, of the course of healthcare systems in the United States. It really started out very early. In 1798, there was a passage of an act for the relief of sick and disabled seamen. And that actually established the first federal network of hospitals for the merchant seamen, a forerunner of the U.S. Public Health Service. But from there, you can see it really took course for a lot of other entities which we take for granted today. The supervising surgeon, which might be called the Surgeon General today, the Food and Drug Act, which looks at the FDA, NIH, our research institution that really helps us promote and gain new knowledge. The CDC in 1946, which really is our nation's outreach for public health. 1965, that's where Medicare and Medicaid, greatly debated today, all started. But it wasn't until 1993 that actually we had a national program which promoted vaccines for children. In 1997, and I'll talk more about this, the Children's Health Insurance Program, which really gave greater access to health care insurance, was established. And of course, we all know that the Affordable Care Act started in 2010. But why does this all matter? Why does this system matter? If I already said that 80% of health actually really isn't impacted by any of these systems or clinical systems, why are we here today to talk about health care? Well, there is a great impact on access to care. So we know several things about children who have access to insurance. Children with insurance are more likely to have a usual source of care. What does this mean? It means if you are uninsured, you are 34.6% of children who are uninsured do not have a usual source of care, as compared to only 2% of children who have insurance that have a usual source of care. Now, if you think about it, when you go to the doctor, you can probably name who your doctor is. It means that you have access to regularly scheduled appointments. It also corresponds with better health, cost-effective care, meaning you don't delay the care when you need it, and reduces health disparities. Children with insurance are more likely to have access to preventive care. In fact, children without insurance, only 55% of them have really seen a doctor for preventive care in the last year, compared to nearly 90% of children who have a usual regular insurance. What does this mean? It means that they're getting their vaccines on time. It means that we're checking into making sure that they're growing and developing as they should. In fact, if we look at vaccines alone and estimate, and look at the cohort of children born between 1994, so remember the Vaccines for Children program started in 1993, to 2013. We estimate that based on the fact that the disease burden went down, meaning children didn't actually get these vaccine preventable diseases, that it actually saved the cost of the healthcare system $295 billion. And then if we consider the disease burden, decreasing the hospital costs, it decreased that cost by $1.38 trillion. That's a significant amount of money, but more importantly, our children were healthier. Children with insurance get the health services they need. What does this mean? Uninsured children are 10 times more likely to have unmet healthcare needs. Think about it. If a child has asthma, but they don't have insurance, how likely are they to get their medicines? How likely are they then able to actually interact with other children, do their usual go to gym class, or just play outside? Uninsured children are 4 times less likely to have access to dental care. Why is that important? Actually, tooth pain and dental caries are the #1 reason that children miss school for an acute illness, which is really a chronic illness, dental caries. Health insurance improves social and emotional development. Now, part of this is really doing, it's the usual screenings. And we know that early brain development that I talked about, we actually screen early on to assure that children are developing as we anticipate. When we intervene early, we can support children, whether it be through speech therapy, physical therapy, occupational therapy, so that they're ready for school by the time they get to kindergarten. Children who don't have this opportunity are 1.5 to 2 times less likely to have vision or hearing screens. Now imagine the fact if you actually couldn't see and you never got screened to see if you needed glasses, how well would you do in school? And then our adolescents, we hear about the growing rate of children struggling with anxiety and depression. Well, without access to health care, we're going to miss the 22% of children who actually have a developmental or mental health condition, and equally important, the additional 18% who are at risk for developing that. We can change a life course by intervening early and supporting children and families. So this kind of gets to the next point. Enrollment in health insurance really can improve attendance at school. If you're sick, you don't go to school, right? Some studies have shown that actually by having health insurance, it increases your school performance by 68%, meaning children are much more likely to go to school. One state showed that merely having insurance alone decreased their absentee rates by 39%. In some years, it's estimated that 14 million days of school are missed because of asthma. Now think, if we have more and more children who don't have access to care, how many more days they're going to miss school because they can't breathe. So I won't read all through these, but the Academy does, as its core, have an issue of access to say our children need support to become healthy adults. And this is core to what we think, one of our core principles. So what does access look like these days? Well, I have to talk a little bit about what the insurance coverage is. We could talk about a lot of things, including how do people get to clinics and where we can look at healthcare transformation. But that first column is really employer-based insurance, which is the #1 way children and adults still access insurance or access insurance coverage. But Medicaid is now the 2nd largest insurer in the country. And of that number, 40% are children. So very, very significantly. Actually, 40% of children are in Medicaid. There's about 36.8 million of that 69 million in that number that are on Medicaid. Historically, though, what we've seen is a real change in the uninsurance rate for children. And that's been a combination of really people working to promote and find children and families who are eligible for insurance, either through Medicaid or CHIP. So if we move outside the employer-based insurance market, this is really how our children are insured otherwise. So you'll see that number, 36.8 million children on Medicaid. That's a significant number. Medicaid expansion CHIP is another 4.7 million. We have our CHIP funding, which is that Children's Health Insurance Program, 3.7 million. And really the marketplaces that everyone talks about in the Affordable Care Act is still not an insignificant number, but as compared to everything else, 1.1 million. wanted to talk a little bit, even despite that, what the Affordable Care Act did. No bill is perfect, and we are not partisan in this issue, only we are partisan for children. And so when we look at any bill, we look for what has benefited children. And so here are some of the things that actually were really positive. There were cost sharing reductions, so families did find some more affordability in cases. Coverage, parents. We actually know that if a parent has insurance coverage, they are more likely to be healthy, they are more likely to get the care that they need. Obviously with that, they can better care for their children. But we also know that children then also are more likely to get the care that they need and get those regularly scheduled preventive visits. We all know about the pre-existing condition exclusion ban, which means that children who are born with genetic conditions will have access to insurance. They won't reach a lifetime limit. That really not only impacts access to care, but it impacts the entire family's well-being. And the dependent coverage through age 26. I came from a meeting with families and young youth, and really the 22-year-old who was part of this discussion said, you know, here I am graduating from college, and what I still know is that I have access to insurance because my parents have insurance, and that's quite reassuring as he tries to determine his next step as he completes college. Benefits. Benefits are really important. Within the Affordable Care Act, there's something called essential health benefits. And this really defines what insurance plans need to cover. For children, it's actually specifically called out pediatric preventive care. Again, investing in children early promotes and ensures that children will attain their optimal health. And that's really the next line, which really says there's no cost sharing for those preventive services. Bright Futures is actually a collaborative effort between public health, clinicians, parents, families. It's been around for over 30 years that identifies and outlines what the best preventive services are and exactly what our children should be receiving as part of their care. So, what have been the outcomes after the Affordable Care Act? The uninsured rate has plummeted to 8.6% for all Americans, and the U.S. children's uninsured rate is at an all-time low of 5%. So everything I talked about, we're seeing fewer children who won't have access to care because they really do have access to insurance. I wanted to just mention the Children's Health Insurance Program. This is a program that really started, again, in 1997. It actually was modeled after a Minnesota legislation to give kids who were above that Medicaid threshold, but really the families didn't have ongoing employer-based or insurance, or it wasn't affordable. So in Illinois, just for your knowledge, children that are 143 to 313% of the federal poverty level for families are eligible. This allows families and children to have benefits on cost sharing, which is considered to be affordable. And importantly, it also outlines quality. So it holds me accountable, and families accountable, and systems accountable to assure that if we're going to have insurance, that we're providing that high quality care, that I am doing things like providing Bright Futures services. 8.4 million children across the country are actually covered. It's called All Kids in Illinois, and 295,000 children are covered in Illinois under this program. The federal government actually matches it, which is important when you think about state budgets. And so about 89% of the cost sharing comes from the federal government. And it's funded until October 1st. So this is really something that's a burning issue for us as well, because this funding will go away for those 8.4 million children should Congress not act. So Medicaid. I mentioned that started as part of, alongside of Medicare in 1965. but it really was started for children, and as part of that, it has some key core elements that really support children uniquely. 40% of children, again, are covered by Medicaid nationally, and up to 50% of pregnancies are actually covered by Medicaid at this time. 1.4 million children in Illinois are in Medicaid, and that means that 5% uninsured rate across the country, actually Illinois has less. It has 2.5% uninsured rate of children. The eligibility is a family of 4 with an income up to $35,721 is eligible for Medicaid. So what are those key elements? There's something called EPSDT, which is a tongue twister if you want to try that yourselves, but it stands for early, right? Early intervention. The earlier we intervene, the better the outcome. Periodic. Children grow and develop. They change right from day to day, so we need to periodically assess and see where their health is. Screening, developmental screening, vision and hearing screening, screening for mental health issues. Diagnosis, from all of that, are there any conditions that we should be diagnosing? And then actually, if you diagnose something, can you treat it? So if you take the last 3, I screen a child, they fail the vision screening, I send them to an eye doctor, an ophthalmologist, who says, yes, this child needs glasses. So therefore prescribes the glasses, and they're able to receive the glasses, all under this benefit coverage. So what's the future of all of this? I was in a conversation this morning where we discussed this, and this is uncharted territory. We know that there is legislation in DC that would actually change the landscape of all access to insurance. It goes beyond the Affordable Care Act to affect Medicaid. And that means that the future of Medicaid is really unclear, and that 40% of our children may be greatly impacted by that. I'm told that the Congressional Budget Office will provide their cost analysis on Wednesday of this week. So if you're looking ahead in the news, that's the inside scoop that I've heard yesterday. But early estimates were that this would really take $840 billion out of Medicaid. It means states would be responsible, $5.1 billion in some states. I mean, just really change things. It would also take away those quality elements and the EPSDT, assuring that, okay, if I screen for that vision test, am I going to actually be able to support the child in the ways that they need? So with that, we are do no harm. Just being physicians at Baseline, we talk about do no harm, but in particular this time around, we strongly state that for our children, we need to preserve and protect Medicaid. We actually believe that we should protect the ACA's Medicaid expansion. Again, children need healthy adults to care for them to achieve their optimal health. And then in this, in Medicaid, it's actually connected to a lot of other systems. Early childhood systems which support children in ways that they need. Education systems. Education is tied to health. Child welfare, juvenile justice. I mean, we actually want to drive down the costs of all of these by doing what's right by kids early on. And so this is a major focus of our organization because we just honestly can't imagine a future where our children are optimally cared for. So I'm going to just put this up and leave this up. This is something that the Academy developed last September. Pre-election, it's called the Blueprint for Children. And this is for anyone in office, really on a federal level, anyone in any federal agency, but it really can translate to the state level. And it talks about and outlines why Medicaid is important, why access to insurance is important. But you go down the agency if you want to know about nutrition issues and whatnot. We'll have issues on climate change and gun safety in there as well. So I think that, and that's a great resource, I hope, for you all as you think about these issues.
Thank you, Dr. Edwards. That was a great presentation on the Academy's position on healthcare. I wanted to just take a moment and tell you what the League's position is on healthcare. And this is directly taken from the League's website. The League is dedicated to ensuring access to affordable, quality healthcare for all Americans. We believe that all Americans should have access to a basic level of care, including disease prevention, primary care, which includes prenatal and reproductive health, acute and long-term care, mental health care, and health promotion and education. I particularly underlined the word prevention and health promotion and education, which goes along clearly with the tenets of the American Pediatrics. You obviously try to prevent. When I was training in pediatrics, I'm old enough to have actually seen very significant measles outbreaks. We still have measles outbreaks. There was one in Minnesota just recently because of lack of vaccine. When I saw those children come into the hospital, the history was that they were very active children, intelligent, spoke well. And when I saw them in the hospital, they had measles encephalitis. So the day before, 2 days before, they were wonderful, vibrant children. And now they're in the hospital, barely surviving. At that time, we used to keep people in the hospital a little longer. And so they would be in the hospital for many times a couple of weeks, even longer. When they left in a wheelchair. They could not speak. They could barely move their extremities. Those children obviously were lost to society and to their family. And not only when we talk about healthcare costs, and the thing that I was concerned about when the Congressional Budget Office reviewed the recent House bill, as you know, they had to do it very quickly. They really just talked about costs of government health care, the cost savings, for example. But when you really do a good analysis, and the Congressional Budget Office has done good analysis, like, for example, on the Affordable Care Act, they look at other costs, societal costs. So, for example, that child or children who now have a disabling chronic condition, there are societal costs to that. And many times, those costs are much more costly than the cost of the health care directly given to them for that disease. So from society point of view, we have to look from a broader perspective than just what it costs for the medical care. We have to look at the cost of society in general. And can you imagine the special education costs and rehabilitation costs of even that one child that had measles encephalitis? So when I taught in medical schools, I usually told a story at the beginning of my presentation on prevention. And the story went something like this. There's a beautiful small community that had a lovely park, a lovely area, open area on a bluff. And it was so beautiful that the city fathers, or village fathers, decided that they were going to put a playground. A playground with swings and baseball fields and soccer fields on the bluff, because you could see for miles, and beyond the bluff there was a beautiful river that you could boat on and that you could fish on. And so they made the playground. After the first year, children were playing soccer, and the soccer ball went near the bluff. And one of the children fell off the bluff little child was severely injured. So the parents ran down the bluff to help the child. They called 911. But the village was small. It didn't have a really great ambulance service. So it took the ambulance a long time to get the child. Well, after this, there was town hall meetings and an outrage. This is ridiculous. The community has to have a better ambulance service. So the city fathers, increased some taxes and they got a better ambulance service. Everybody was very happy. The next year, kids were playing on the bluff and they were playing baseball. And a baseball went near the bluff and a child fell down the bluff. Oh man. So the ambulance came, it came very quickly. The money was well spent, it came quickly. In fact, the money helped other people in healthcare getting to the hospital sooner. So they brought the child to the emergency room at the local hospital, a small hospital, local community hospital. And it didn't do a really good job because they didn't have the equipment and the staff to take care of the severely injured child. So the hospital got together with community groups and donors, and they decided to increase the capabilities in their emergency room. And in fact, they did do that. And people were better treated when they got to the emergency room. The third year, child was playing with their peers, hide and seek, or tag. And when they were going near the bluff, when that children fell off, oh my heavens. Well, the ambulance picked up the child, brought him to the hospital quickly. The emergency room did great care. And they were hospitalized because they had severe injuries. Well, the hospital care wasn't the greatest. They didn't have a pediatrician on call. They certainly didn't have a pediatric neurologist for the head injury. And so everybody got really concerned. So again, the hospital is asking their donors and get better health care. Well, there happened to be a medical student in that community that was home for the summer and was working at the hospital for doing some basic clinical work at the hospital. And at the town hall meeting, he said, why didn't you put up a fence? A few $1,000s, why didn't you put up a fence on the bluff? Well, when I tell this story, the medical students in the audience get all riled up. And they say, Dr. Patrick, of course people would think of that first. That's prevention. They would think about building a fence first. And so many of the medical students in my evaluation would say Patrick was dumb with his story. But the point of the story is we spend $3 trillion a year on healthcare. And what percent do you think we spend on prevention? We spend no more than 5% on prevention. 5%. So when you look at the story says we prioritize at least 95% of our healthcare dollar on healthcare, but we give little thought to prevention. So the story is supposed to make people think more about, first think about prevention, and then think about resources for primary care. So what does the $3 trillion give us? Well, the United States ranks 37th of developed countries in our healthcare system evaluation. 37th. We spend more than twice, more than double per capita the amount of health care than the average of all the other developed countries. More than double. And we rank 24th out of 30 nations in life expectancy. 24th out of 30 developed countries in life expectancy. And through a number of different analysis, about 75% of our healthcare costs are actually related to preventable conditions. So we really have to rethink how we prioritize our healthcare dollars. The last thing I want to comment on before any questions to Dr. Edwards is in prevention, we have a term called compressed morbidity. Compressed morbidity. So what does that mean? Well, I usually like to say it means that we have the hope of dying in the remote future in perfect health. Think about that. So we have the hope of dying in some future time in perfect health. So what compressed morbidity says, we're all going to die from the same stuff. First of all, we're going to die of heart disease, cancer, stroke, pulmonary conditions, kidney failure. We're going to die of all that stuff. It's not going to be different. Well, maybe, you know, if you go to a South American country and get some, infectious disease, you might die from that. But then generally speaking, those of us in the United States are going to die from, 4 or 5 major causes of death. But what we'd like to do is we'd like to have a shortened period of disability. So we want compressed morbidity. So we want to be healthy enough to take care of our kids and grandkids and enjoy travel and that sort of thing. And so we want to be disabled for the shortest time possible. To do that is prevention. Okay, so some questions. Has the Academy noticed a correlation between cuts to education funding and to non-academic subjects such as PE and childhood obesity?
So the issue of childhood obesity is complex, I have not seen anything that, shall I say, specific cuts because actual physical activity in classes varies so much. So what is physical education in one classroom versus another is very different. What we know is what the community does and what it says is important and it values in terms of walkable neighborhoods, access to safe parks, combined with educational opportunities that include physical activity, that those children tend to do better. But again, I think that the issue of saying one area leads to, when you cut PE, it automatically increases obesity or vice versa. It really, you need all of the components. Food insecurity, making sure that our children have access to healthy fruits and vegetables. I mean, all those things play into childhood obesity. So do I support physical education in classrooms? Yes, I support it for well-being. I also support it for learning. We know that kids who are active and have different activities actually do better in educational attainment too, rather than sitting. Imagine yourselves, you can recall how long you had to sit and how well you paid attention and how much you learned. And there certainly are models where we see children actually learn more, gain healthy lifestyles which keep with them by intermixing physical activity in classes.
Very good. One of the issues about the Affordable Care Act and having people more insured is, of course, the insurance is just a method of getting people better care and prevention, right? So one of the big issues is, well, are there enough physicians to take care of these more patients? And so the question is, are there enough pediatricians to treat all the insured children now?
So I'm going to answer this there are some areas where there are adequate pediatricians. There are many areas that there are not. Where pediatrics differs actually is, and this is actually because of the training system, is we actually lack certain specialty care for children. And certain specialty care that actually really is very, very important. So I talk a lot about developments in mental health. Those are two areas where we lack specialists with unique training to support children with developmental issues and mental health issues. We also know that geography matters. There are some areas of the country where there are adequate pediatricians, and there are other areas where there are not. So you may live in an urban or rural area where your ability to access the care you need may be very difficult. And for that reason, one area of the Affordable Care Act that sometimes gets unrecognized is it actually has opportunity for innovation. And there are some areas where states can do some very innovative things to look at what we would call population health, look at the needs of communities and say, how could we transform the system and use things like telehealth or bring new providers in for the needs of the community.
One of the things we forget when that question is asked or concerned about it is that, again, in prevention with children, the whole goal there is to have them reach their potential and not develop chronic diseases and disabilities, right? So, and additional costs with education and schooling and stuff like that. So when you talk about getting them access to health care, as Dr. Edwards has shown, that really diminishes a lot of those chronic conditions and costly conditions. So when you talk about a healthcare system, the more chronic conditions you have, those are really very expensive, right? So for example, women that don't have health care are 4 times as likely to have the fourth stage of breast cancer. So you can imagine the cost of a mammogram or a physical examination versus the cost of the 4th stage of cancer and what that costs. Not only healthcare costs, disability, but also obviously the cost to the family, the trauma to the family and the disruption to the family unit when that occurs. So we have to keep in mind that giving people better insurance actually prevents a lot of these more costly chronic conditions. There's a question about safe water. Must be talking about Flint. We know that the Flint lead situation was a disaster. Again, when I was in pediatrics, I saw a lot of kids with lead poisoning. But that lead poisoning happened to be because there was a lot of lead paint on walls. And for some reason, kids like to eat it. Well, you know, lead paint in interior walls and lead paint, and that was banned a number of years ago. So we don't see there very much enough lead paint anymore, but we do still see lead poisoning. So the question is basically, do we have really clean water in the United States, or do we need to really think about that a little bit more, similar to what occurred in Flint?
Do we have clean water? So Flint raised a significant issue of our public health infrastructure. And part of prevention, again, is public health. Well, I may work in a clinic and I can support families while they're there. The public health system goes beyond in the community and is one of my partners. I think Flint demonstrated just without robust funding, without constant watching, without us being aware of our surroundings, how that can go very badly, poorly for children. So I think it raises an awareness that we can't assume that anything is gone, unfortunately. We need to be vigilant for our children. If we know this has been an issue in one area, we need to assure that we support the public health system in continuing to monitor. We need to be aware and continue to screen. That screening element of Medicaid actually, and this is the reason Hannah discovered it, is she was seeing children who had access to care and had insurance, and so were screened for lead and suddenly said, wow, there seems to be an uptick in this. Again, it actually, from that, the insurance coverage actually helped us prevent even further problems for the children in Flint, Michigan, which is not that it's not horrific, but it could have been even worse without that access to insurance.
The question also leads to kind of an issue of competency in the public health arena and other medical arenas as well. There's sort of a sense, sometimes in government, well, there's a lot of waste, so we have to cut services and we cut staff. Well, I ran for health departments at local, state, and national level. And when you recruit for professionals that have to have some fairly significant credentials, when you cut services and programs, for example, you cut the CDC on injury or infectious control or lead poisoning, you cut those positions out, you let go well-qualified people generally, and then there becomes a crisis. And now all of a sudden, society is looking to government to solve that crisis. So, for example, when I was a state health officer, and I had to lose some staff in my infectious control program, all of a sudden there'd be an outbreak, and all of a sudden the state legislature said, we have to control this outbreak. We have to send staff out there, take case histories, clean up wells, whatever the reason for the outbreak was. Well, you think I can get well-qualified people, overnight based upon an outbreak? Of course you can't. You have to have a core set of competencies, and I think maybe Flint, Michigan had a little bit difficulty with that. I don't know that for sure, but the point is, in public health, like in anything else, if you're trying to protect the public, you have to have a certain level of core competencies so that when something happens, you can respond. You can't take 6 months to recruit new people and orientate them, because by that time, many people have died or have been hospitalized or severely injured. So the issue of looking at these public health concerns and programs really do have to have significant funding on a constant basis. And as we're seeing in some of the budget proposals nationally, there's significant cuts. I forget what the CDC cut was going to be, but a third or something like that. Some phenomenal number. I mean, it's tragic what's going to happen. It's really going to be tragic. And the sad part is, it might happen, not 5-6 years until it's a major outbreak. But when that happens, then society is going to say, government, you didn't do your job. The next question has to do about insurance. And this will be the last one we'll take. And it basically says something like, does insurance really help outcomes? I mean, is insurance the method that should be considered and looking at good health outcomes?
So I think by all the slides, if we believe in prevention, right, in children who are uninsured, 55% of them do not have a usual source of care, which means they're not really gaining care, they're not getting any preventive care. They have conditions that are maybe that really are not being treated. So they will escalate, they will not achieve their optimal health. Steve mentioned that some of the rankings of the U.S. Actually, U.S. children rank last in health and well-being. For all that, well, we don't spend a lot of money on children. That's my bias, but so it is one of the markers. Because you have insurance does not always mean, and we have to look at the entire system, that you have all the access to the care that you need. And certainly we could talk as well about zip codes and how much it matters where you live, which again gets into issues of everything from food to housing to public health infrastructure as well. But yes, it definitely is one of those markers in that entire system that is important for optimal health. So we're going to shift gears maybe a little bit, but again, I think that this is all interconnected when we think about our children's environments. And again, I want to challenge everyone. We're giving data here, and data matters, but stories matter, and motivation matters. So when I work with residents and students and I talk to them about advocacy and getting engaged in the community, it really draws upon something that probably has happened in your life, to you, to your family, to a close friend, to a child that motivates you. And those stories are really what starts the dialogue, what starts the conversation with a political member or anyone else in the community. And data really helps to support that. But the story of the fence is a classic preventive story, and it's a really important one, which reminds us that we all have a part in this as well, and we can think outside the box, but stories matter. So climate change. I jokingly said this week was a little bit about climate change, but I think every week is a little bit about climate change as you turn on the weather, and the weather is always a story these days, right? There are tornadoes, there are torrential rainfalls, now it's snowing. I talked to someone in Montana that, the snowplows are put away in Montana even at this time, and they're getting 2 feet of snow, and is that normal? Is it not? So this is from the Lancet Commission. Climate change is the greatest public health opportunity of the 21st century, and failure to adequately address it could undo most of the progress in global health over the past century. We're going to kind of go through some of the elements of that. So it imposes a threat to human health and safety, but children are uniquely vulnerable. Again, children are not little adults, and the way that they interact with their environments are unique. So according to the World Health Organization, more than 88% of the existing burden of disease attributable to climate change occurs in children younger than 5 years old. Okay, now I have to tie it back to healthcare, right? So we talked about healthcare, but as part of that, we talked about prevention, and I talked about early intervention, and I talked about brain development, and 90% of brain development happening in the first 5 years of life. So how do we become healthy adults if climate change is already impacting us as well? This is kind of like an extra we're going to, unfortunately, maybe layer on to our children. But again, our children, this generation, it is predicted will be the first generation that does not have a life expectancy that increases as past generations have. Our children are just really increasingly at risk. So heat waves. It's not a heat wave yet, though. I moved here in February and spent a week where I really assumed I would have a snowstorm to deal with, or at least cold weather. And yet I barbecued in the backyard and had 80-degree weather. That wasn't quite what I predicted. So how does this impact children uniquely? One study actually projected an increase in infant heat-related deaths. So we've heard about this, right? Children, unfortunately, being left in cars or forgotten or just in environments where they have undue heat exposure. And so the study predicted that there will be a 5.5% increase in female infant deaths and 7.8% in males by the end of this century, which is a significant amount of children. From 2000 to 2010, the number of deaths in American high school and college football players ages 15 to 29 doubled. This isn't because they're taking extra practices or working harder. I do come from a farming community in Minnesota. People work really hard on farms. They did a lot of physical labor. This is really because of the heat and the work at the same time. So extreme weather events. Not only do they threaten the lives of children, they actually increase the risk of mental health problems. Now, what does that mean? I think that, I don't know who has lived through a natural disaster. I actually won't use an example of a child initially. My parents actually live in northern Minnesota and lived through 18 inches of rain in less than 24 hours. They live on the top of the hill and their home flooded. To this day, when my mother actually hears rain that is heavy, I can see her anxiety level get high. She wonders if she should go home, she wonders if she's safe, she wonders what to do. And fortunately, we can really support her, and this is unlikely to happen again, but maybe it's not. And it also can have lasting effects with homes and communities are destroyed. I worked in North Minneapolis, an urban community. In the day of the Joplin tornado, which was a terrible, terrible event, there was a tornado in North Minneapolis. Probably none of you ever heard of it, and it went off the radar, but not off mine. North Minneapolis is an urban area, higher concentration of poverty, but also an area where people have risen into the opportunity to potentially buy their first home, but barely. That tornado wiped out most of those homes. And many of the families and children that I interacted with no longer had a home. Weren't sure where they could possibly find the money to live, became homeless. And I started to see the children actually struggle in school, have more behavioral issues, if I could actually see them and find them, if they had transportation to get to my clinic. So this happens over in communities that really are vulnerable, and they have something like this happen, which is unpredicted. We don't usually have tornadoes like that destroy entire neighborhoods of Minneapolis. We have tornadoes that kind of think about touching down, but never quite do. And that's how it can really change the entire community. Many of those homes are still boarded up. So what else does climate change do? Well, there's an increase in infectious diseases. So Lyme disease. Lyme disease is actually a disease that occurred in river valleys, and actually it has been in Minnesota for a long time, but if you look at the map, it now occurs most everywhere in the US. Why? Because the vector, the deer tick, is actually able to survive in a lot more places than it was previously because of the change in weather patterns. And therefore, many more people have the opportunity to actually be exposed to Lyme disease, which, if caught early, is treatable, but many times it's difficult to catch and can cause significant morbidity. Diarrheal diseases. This actually gets down to a bioecosystem where the rivers and lakes are warmer, you have runoff into the ocean in different places, so the actual ecosystem changes, and organisms which actually, they thrive in these new environments. And then we consume the water, and hence diarrheal illnesses. Zika. I think everyone's heard of Zika. Zika actually, as you were talking about the ability to respond, this has taken significant resources. It came on the heels of Ebola, which also took significant resources. These really outbreaks or changes are happening more and more rapidly. We don't have a break. Optimistic it would be 5 years before something new. But we don't quite know the impact of Zika. We know that it keeps marching north, that the mosquito that carries the Zika virus is living in places as the climates become warmer. We are starting to understand the impact of neurologic conditions. Most impact is on infants, though elderly have the potential of having neurologic impacts as well. We know that children who really are profoundly impacted by the Zika virus will have a lifetime of morbidity, not just costs in dollars, but costs in what the family needs to do to support children. And if you've ever had a family member struggle with a child that is born with a condition that you really don't know where that's going to lead, that actual anxiety and concern is truly significant. And then parasites, which really follow a lot of the diarrheal diseases as well. So ozone action days. I've not been here in a summer, but I never used to hear about these in Minneapolis. It was Minnesota, right? We had lots of green trees and everything was non-polluted, or so we thought. We had weeks of these some years. We know that burning fossil fuels increases the air pollution, and then combined with warmer air temperatures, this increases the ozone action days. They're actually declared when weather conditions are likely to combine with pollution emissions to form high levels of ozone near the ground that may cause harmful health effects. Again, where I practice, and many times this disproportionately affects certain denser urban areas where children therefore aren't able to go outside during the summer, they're not able to go outside during gym class. I start to see an uptick in asthma in the office. I start to see upticks of children just not feeling well. I've actually had families where parents can't go to work because of their chronic conditions and chronic respiratory illnesses, and then the family starts to have actually financial impacts. This correlates very closely to the fact that we actually know that asthma rates are higher in some communities. Are these ozone action areas? Not necessarily, but we do know that if you live closer to a highway that there have been reported increased rates of asthma, and therefore you also are likely to have more of these ozone action days, and that's again a double concern. So climate change and food insecurity. This is maybe people think about this a lot, but this is an area of concern for us. We say so there's increased atmospheric CO2 impacts the grain quality. So what we're growing just isn't as healthy. We're not growing as healthy as children, we're not growing as healthy a grain. It lowers the protein content of edible portions of wheat, rice, and barley, which really sustain many people throughout the country and the world. And this again, we're just layering on the impact of climate change. So for us, climate change is health policy. It is different, but no different than vaccination programs, tobacco legislation. We talked about lead, the removal of lead paint from gasoline, and we feel that we all have a vital role to play in climate change. It's just core to who we are. I think that it's a little bit surprising that we're having to address this as much as we are in recent time. So we actually are part of a medical society consortium on climate and health, which is actually 400,000 strong, and the Academy was one of the founding members of this. It includes some of the largest medical societies, and while I'd like to say we come together always as medical societies, we don't. So the fact that climate change has brought us together also signals how significant an impact we think this has on the health of not only children, but the entire population. And there are 4 things that this consortium really outlines. Climate change is harming Americans today. Not in the future, but today. And these harms will only increase unless we act. The way that we can really act is to decrease the use of fossil fuels, increase energy efficiency, and use clean energy sources. And with those changes, the quality of our air and water will bring immediate health benefits. If we can decrease the ozone action days and our children can be outside and play and feel healthier. Someone asked about obesity earlier. Okay, this is why these are all combined. To pick one policy or one issue, you really have to combine all of these. So the Clean Air Act, it passed nearly more than 40 years ago. Initially in 1970, it's been revised in 1977, and then again in 1990. And, you know, it really has had significant impact. They looked at the first 20 years, so between 1970 and 1990, and they estimated that it actually prevented 205,000 premature deaths, 672,000 cases of chronic bronchitis, 853,000 asthma attacks, 18 million childhood respiratory illnesses. And actually, because that lead paint was part of this, it prevented the loss of 10.4 million IQ points for children from lead exposure. That sounds like a policy that really promoted health. So we liked it. In fact, we liked it and actually think that the Clean Power Plan, which has been proposed by the EPA, would build upon that. In fact, if it were fully implemented in 2013, this proposed rule would result in 6,600 fewer premature deaths, 150,000 fewer childhood asthma attacks, and 180,000 fewer missed school days. Because again, kids would feel well enough to go to school. We are proud to be the first medical organization to actually address the health impacts of climate change in our 2007 policy statements. And we continue to testify to support these efforts. Of course, in March, the President signed an executive order on energy independence, which would undo the Clean Power Plan. So what can we do? This is where I actually highlight that there are individual things. This is where I feel like an individual, anytime I talk about climate change, I go home and say, okay, what am I doing? What am I doing to decrease my carbon footprint? When can I walk? When can I take a bike? When can I do just small things that together, collectively, can make an impact? So we can reduce energy consumption and waste. We can look at ways that we individually, but all of us as communities, can decrease our reliance on fossil fuel, look at wind and solar options. But we also need to educate and advocate. When you hear about some of these issues, and I talk to peers, it kind of seems, people think, well, that's in the future and it might happen, but it's not really happening. And we need to go back to ozone action days. We need to go back to, boy, does it really make sense that we're having all these changes in weather patterns? Wait a minute, let's look at it. Why is Zika happening now? Why are all these illnesses that we didn't expect to happen? Is there a role of climate change? So, this is from our policy statement in November 2015. Although uncertainties remain regarding risks and appropriate policy response, failure to take prompt, substantive action, given our current knowledge, would be an act of injustice to all children.
Well, as I said at the beginning, I'm going to take a couple minutes giving you the League's position policy on climate change. And this is directly from the website. Climate change is the greatest environmental challenge of our generation. The League works to build grassroots support for action on climate change nationally and at the state and local level in order to avoid irrevocable damage to our planet. The League supports legislation that seeks to protect our country from the physical, economic, and public health effects of climate change while also providing pathways to economic prosperity. We work to protect air quality by advocating for federal air pollution controls on industrial processes, governmental installations, fuels, and motor vehicles. I want to just discuss just a couple of concepts here. You talk about ozone warning days. My grandkids have really enjoyed soccer, both the males and the females. And I noticed last year, actually the year before I first noticed it, that the kids were really energetic and actually fairly fit. But when they played soccer on ozone action days, I saw kids coming to the sidelines holding their chests. These are not asthmatic kids, holding their chest and being fatigued. And then on another day where there wasn't an alert, I didn't see that happen. So periodically through the summer, there was a direct correlation between these ozone action days and the kids having some respiratory difficulty. And they couldn't play the whole game, individual kids. So when Dr. Edwards says it's today, it's actually happening now, that's a very direct local example. If you clearly observe children in that atmosphere, in that environment, you see that actually that's actually occurring. And again, these are healthy, dynamic kids. The other thing that I wanted to briefly mention, and I really do like Dr. Edwards' statement about what we can do personally, and that is really helpful. And I believe it. But I'm going to suggest to you that the advocacy and the national policies and the national regulations really are the things that change our environment and our behavior. I'll give you a classic example. Again, when I was many years ago, a young physician, I would see many children with vaccine-preventable diseases, many children, including polio. And the positions in many states were, well, this is a parental responsibility. Vaccines were available. It wasn't as high cost as they are today, healthcare. And so we'll just encourage families to get their children vaccinated. What happened with the vaccination rates? Can you see my hand? They didn't do anything. Well, a few states started to say, you know, this might be a good policy. We should make a law, and we should say that schools, before admitting to school, you have to have certain immunizations. The vaccination rates went up. When all the states are doing that, the vaccination rates went way up. In fact, way into the 80%, 90%. And then the Vaccines for Children program came in where they reduced the cost of vaccinations and the availability of them, and they continue to be up. So my point here is that we can do much individually, but when we look at societal benefits, pervasive, big benefits, we are talking about pervasive regulations, things that are required of society for the common good. That's why the Clean Air Act is so important. So whatever our advocacy is, we got to remember that our primary advocacy needs to be on regulations, on laws that protect the public's good. Questions? Does the Academy have, I presume, an internet or web resource for parents in which they can view the AAP's positions on climate change and advocate as parents, grandparents, etc.? So do you have a position, and there is a mechanism that parents can tune into that position?
So the Academy has a website called healthychildren.org, which is our family-facing website that will include information on environmental health and like topics that you can access there. I also think that you will easily be able to find, given the amount of time we spend in DC through our Council on Environmental Health and part of our partnerships with public health, testimony and other elements that are easily available through the internet as well as part of the public domain. But we also can provide some of that information to the league as well. If that would be helpful for your link to your website.
Thank you, thank you. One of the other things is how climate change affects children in many other ways. And we do know that wars have more detrimental effects on children than any other population. And right now, for example, it's unprecedented, but there are 4 African countries that are in severe famine. And severe famine because of drought. There's not enough water for their crops. What we see, and we have seen historically, when there are food shortages, those shortages create wars, which clearly impact upon the health of that whole community, that whole nation, many times globally, the world, but also that significantly impacts our children.
So the last topic we'll talk today is about gun safety. And I always start this conversation with the fact that I am an expert in child safety. I'm not an expert on guns, but I'm going to talk and hopefully have a great conversation about how we can keep our children safe, which is a continuing theme. How do we keep them safe through preventive care? How do we keep them safe through promoting optimal policies around climate change? And now how do we keep them safe from injury? So a little bit of background. This is from 2015. Firearms is really causes significant harm to children. Nearly 1 out of 4 injury deaths ages 1 to 19 are the result of firearms. 31% of all injury deaths age 15 to 19. And we estimate 2,824 deaths younger than 20 years. I'll get back to why that's an estimate in a few slides. So I also like to start by kind of commenting and laying the groundwork. I know that you're here to look at policies, so I have some maps just looking at what policies are across state, because there really are few federal policies to promote gun safety. So this is really just a map of the states that have looked at assault weapons bans. Universal background checks, you'll notice Illinois is one of those. Waiting period requirements. And then licensing of gun owners and purchasers. Safe storage. Now this is important for us because, right, this is an element. If guns are stored safely, how do kids? It makes it more difficult for children. put a pause here and say, why am I showing you these? There actually have been studies through public health that show that states who have taken issues around gun safety and actually passed legislation have fewer rates of suicide. So they've looked at this and said it really does make an impact. And in fact, in states that then back off on some of those legislation, they've actually seen an uptick in suicide rates. So this is an area where when we combine all of these policies, we start to see something that really has evidence behind how it's impacting and improving on the health. Design safety for handguns. So again, this is the slide, which if you go back, the numbers I quoted are a little bit different than what's shown in this pie chart now. Now I'm going to show you a chart that says 100 unintentional injuries, 1,000, just over 1,000 suicides, and 1,645 homicides. Now, why do these numbers differ? And they'll differ again later. Actually, in the 1990s, the CDC lost its funding to really study deaths by firearms. So when you start to see the numbers, it's really difficult to track. There are places that track it through really news reports now, the internet. There are some ways to extrapolate the data, but it's exceedingly difficult because public health agencies have not been funded to really follow this and to understand it. And there are limited studies for us to really look at then about best efforts to how we're making an impact. These are likely low estimates. That's what we know. What else do we know? So we know that children actually commonly live in environments containing unsecured firearms. A few slides back, I talked about, it showed the states that actually say you do need safe storage of firearms. Children have the ability to fire guns. I think that they're not difficult. Young children are curious. So think about it. Think about all the games that children play. They're curious. I mean, they can take a box and make the most fun game out of everything. So they're curious. They look into things. They poke. They push. They do things like that. Older children are impulsive. I like to remind people, because I'm a pediatrician, that brain development, well, 90% of it occurs in the first 5 years. We call frontal lobe, or executive functioning, really doesn't fully develop until somewhere around the age of 26, and there's a gender difference. So that's where that impulsivity comes in. So guns, unfortunately, with that impulsivity, are particularly lethal. And if you're impulsive and have a gun, it's likely to have an impact, unfortunately. So a study recently was done that really looked at gun storage practices and the risk of youth suicide and unintentional firearms injury. It was a case-control study of incidental, fatal, and non-fatal gunshot wounds of those younger than 20. The controls were households with at least firearm and children living in the home. The exposure was really how the firearm was stored. Evenly matched. Of the cases of fatalities, 95% were fatal suicides. Case guns were 70% less likely to be stored unloaded than the control guns. So what the study showed that is if you had safe storage of the firearms, it made an impact on the suicides for youth. They were 73% less likely to be stored locked in those, converted suicides. They were 55% less likely to be stored separate from ammunition, and 61% less likely to have ammunition that was locked. All these differences were significant, showing the impact that safe storage can have on preventing suicides, again, for youth. So what do boys do? This gets to the curiosity if they have a gun. There's another study were 8 to 12-year-old boys. They were put in a room, and maybe some of you have seen this because certainly it's been reported in the media. And they were put in a room for about 15 minutes with a .38 caliber handgun hidden in a drawer. And 72% of the groups actually found the gun. Again, you're locked in a boarding room, you have your buddy there, and you're going to find it. And in 10 of those groups, so about half, the trigger was pulled. And half didn't really know if it was real or not, but that didn't seem to impact whether or not they pulled the trigger. What else do we know? We know that suicide attempts involving a firearm more often are fatal. That's as compared to overdoses or other method attempts. Guns in the home are associated with an increased risk of suicide, including youth suicide. The guns in homes of youth suicides and unintentional injuries are less likely to be stored, unloaded, locked, and separate from ammunition. Again, that's the study I just mentioned. And so people will say, well, if I'm not depressed, how does this impact? And what we also know from studies is the presence of a firearm at home increases the risk of suicide even among those without a previous psychiatric diagnosis. The theory behind that is that impulsivity. And we hear stories on the media, something happens that's really significant in an adolescent's life, and they have access to a gun. One of my fellow pediatricians just had that happen to them. So it's what we call a perfect storm. I'm not sure if that's always the correct language. A curious child or a depressed, impulsive teen. There's no supervision, no one's around. There's an opportunity, and there's an unsecured firearm. But here's a little bit of optimism. What else do we know? We know that parents are receptive of discussion of the risks of guns during pediatric visits. And we actually know that anticipatory guidance, this is prevention, on safe storage of firearms is likely to result in more guns being safely stored. How do we know this? Well, actually there was a study done, and it was funded. And it was a randomized controlled study, and for those of you who, I don't know how many scientists are in the audience, that's kind of the optimal study. And it looked at 124 practices with nearly 5,000 children and families. And basically, each family was counseled and then provided with cable locks. And it resulted in the safe storage and use of those locks. In fact, it's something called never needed to treat, which means for every 2.5 families that this was discussed, there was actually successful locking and storage of that firearm. I'll actually share a story from my practice. I practiced and had a teen who was struggling with depression. And as part of the process of assessing how I could best support them, I always talked about safety in the home. Starting with what medicines are in the home, how are they stored, do they need to be there, leading into the discussion of firearms. Now, this teen's father worked for Pheasants Forever. And had quite a few hunting rifles. In fact, because of a move of the office, those hunting rifles had been brought back home. The teen knew that. The look on the mother's face when she realized she hadn't recognized that these rifles were now in the home and that they weren't stored in a safe area, I still will never forget the look on her face and how the color drained out of her face. The guns were safely stored, and the mother thanked me the next time she came in saying, I just didn't realize, it just didn't cross my mind. I was so worried about my child, I hadn't thought of all the other safety implications in my home. So I wanted to share a little bit about a journey that the Academy has gone on regarding this discussion to improve and prevent injury from firearms. And it really begins in 2011, so that's 6 years ago. And that's about the time I started on the Committee on State Government Affairs with the Academy, and I got a call from our analyst and said, we have an issue in Florida. And the issue was that a Firearms Owner Privacy Act was signed into law by Florida Governor Rick Scott. And the law basically would send any physician reported by a patient or the patient's family for asking about guns in the home before the Board of Medicine to be sanctioned. Actually, that was the lesser version of the law. Initially, it was jail time and a significant fine for asking about a safety issue. Again, we asked about all sorts of safety issues, pool safety. What else is, I talk about stairs and putting up gates, burns. This is part of what I do, is prevention. So this is also a story of advocacy, because immediately following this, the community came together and said, wait a minute, our children need to be safe. We are talking about the safety of children. So the Brady Center partnered with us, the Florida chapter of the American Academy of Pediatrics, family physicians, adult internists, and along with 6 individual physicians, 5 who were pediatricians, to really have an injunction against this law. And the plaintiffs argued that the law violated their First Amendment free speech rights. So initially, the U.S. District Judge ruled in favor of the physician plaintiffs. Then the Florida Attorney General appealed the ruling to the U.S. Court of Appeals for the 11th Circuit, and this was in July of 2012. So what happened from there? On July 25th, 2014, now you'll notice a long time had passed, so this is hanging over the heads of every Florida pediatrician wondering, even though it wasn't really law, this added attention to how they were going to support children. So that a 3-judge panel ruled that there was no First Amendment protection for physicians providing best medical advice to families. States have a legitimate interest in preventing physicians from discussing any issue that they find distasteful. And that was the language used. And good medical care does not require firearm inquiry. The clinicians were not inquiring about the firearms, they were inquiring about the safety of the children in the home and trying to partner with parents to support that safety. So the journey continued on, and following a petition for rehearing by physicians, in a 2-to-1 decision, the 3-judge panel rescinded their previous ruling and issued a new ruling. They maintained the position that Privacy of Firearm Owners Act was constitutional. The state had a legitimate interest in regulating physician speech. But then they used different First Amendment arguments to reach their conclusion. And this became a web of legal, I'm not a lawyer, but we were in it really for the children, and we were fortunate to have the Brady Center and some very astute lawyers partner with us. So finally, what happened was there was a petition for a rehearing by the entire 11-judge panel in the 11th Circuit. The rehearing was finally granted in 2016. Remember, this is 5 years later. And the prior ruling vacated by a full 11-member panel. So the oral arguments started 9 months ago, or 11 months ago. And the injunction fortunately remained in effect during the entire trial. Finally, this year, 6 years later, in a 10-to-1 decision, so clearly overwhelming, the U.S. Court of Appeals for the 11th Circuit upheld a lower court ruling against the Florida's Privacy of Firearms Act. It really was considered a victory for children. It protects the physician's First Amendment rights to counsel patients about safety. However, the court allowed a provision that prohibits discrimination against firearm owners by physicians to stand, which we support. We're talking about safety. The decision notes examples of a physician failing to return messages, charging more for the same services, declining reasonable appointments, not providing test results on a timely basis, or delaying treatment because a patient or a parent of the patient owns a firearms as activities consistent with discrimination. None of these had occurred prior to the ruling, but it's part of the ruling. The state of Florida expended a significant amount of resources and time, and we anticipate that may be a deterrent to similar initiatives. But the state of Florida also now has the option to appeal the ruling to the U.S. Supreme Court. And it's unclear what their future action may be, so we continue to monitor this situation. We'll note that the pro bono legal team and representing the Florida chapter and plaintiffs were recognized by our academy really for outstanding commitment to child health and to ensure that pediatricians can support that health through promoting child safety. Following Florida, which was the first state, you'll notice how many other states actually introduced similar legislation. So the journey is still a little bit, well, we're optimistic, unclear. So what did this teach us? Well, advocacy, as in many things, is not a sprint, it's a marathon, and you need to know your expertise. Again, I started this by saying my expertise is in child safety. This was about child safety. I became a pediatrician to promote the health and well-being and safety of children, and that's core to who I am. Know your data as much as you can. Support your stories with data. What happens, we know what happens with curious and impulsive children, so use that to support. And provide clear, consistent messages. So with that, I'll take questions.
So again, what I want to do is I want to actually read to you the League's position on gun safety. In efforts to protect public health and safety, the League supports a number of federal measures to limit the accessibility and regulate the ownership of guns. Since 1990, local and state leagues have held community meetings testifying before state legislators and organized rallies to implement gun safety measures that will protect all Americans. The League supports legislative controls to stop the proliferation of handgun ownership and irresponsible use, and restrict access to automatic and semi-automatic assault-type weapons, as well as the regulation of firearms for community safety. Just give you a few statistics. When people think about guns, they think about generally homicides. Well, actually, there's only about 11,000 homicides with guns in the United States. But how many suicides are there? 21,000. So almost double the number of homicides or suicides because of guns. But that's just, again, the tip of the iceberg. You know, we talk about prevention, we talk about, you know, the tip of the iceberg being death. The bottom part, or the middle part is really that there's about 73,000 non-fatal firearm injuries in a year. Non-fatal. So again, you can remember how cost, disability, chronic conditions. So I want to mention something about additional costs. There's about $48 billion in healthcare and work loss costs every year because of firearms. But there was really an interesting study that was just published in March in the American Journal of Public Health. If you look at the rate of suicides, the national rate of suicide since 2005, you will see that it has steadily increased in that time. Every year, the rate of suicides has increased since 2005. In fact, now it's a 30-year high of about 13 suicides per 100,000 people. 30-year high. So what did this journal article, research article, basically show? Dr. Edwards showed states that have different laws. And one of the laws is that you do better universal background checks. Well, those states that had universal background check laws compared to those that did not had a decrease of 0.29 suicides per 100,000 people, a decrease. When you looked at the same states, this was in 2013 to 14, they had an increase of almost 1 suicide per 100,000. So, universal background checks, a decrease in suicide rate. Those that didn't had an increase. The same increase that had been seen nationally over the trend of those 30 years. If you had a mandatory waiting period, there was a decrease in suicide rates. Those that didn't had an increase in suicide rates. So if you took them both together, in other words, state that had both laws, universal background checks and a waiting period, you had a decrease of almost 1 per 100,000 suicides. For those that didn't have the laws, they had a 1 per 100,000 increase in suicides. So again, advocacy for laws is important to change our behavior and what happens. And the basis of that is pretty simple, right? If you have someone who's thinking of committing suicide, if they have a gun in the house, they do it. If they don't have a gun in the house, or they're waiting to get a gun in the house, or they didn't pass a background check, maybe that reason for suicide has been dissipated somewhat. Okay, do we have a question? Okay, thank you. Because CDC has no funding to track firearm deaths, what other sources did the pie chart talk about as far as resources?
Those were, they're really state public health. Some state public health agencies have looked at that. Again, there are some other tracking, whether through media and other sources, but some local public health, some independent funders have done some of those extrapolations. But
you know, actually, as I recall, and I hope I'm recalling this correctly, I think I am, Congress actually by law prohibited the CDC from looking at firearm.
That is correct. That is correct.
So it's not just funding, it's the law says, CDC, you can't look at this particular injury. They don't say that for vehicles, right? They don't say that for poisoning, they don't say that for that, but they specifically said you, by law, cannot investigate the impact of firearm injuries. Okay, I think we're going to have to close up. So, first of all, I want to thank Dr. Edwards for her excellent presentation. Certainly has given us a lot of thought, particularly in relationship to policy issues. And clearly American Academy of Pediatrics, and in my professional experience, has been a leader for child health. And as we all have said, repeatedly, that the measure of a nation is how it treats its children. So, I'd like to give Dr. Edwards a clear round of applause and appreciation for the training. It was exceptional. It was exceptional. And I wanted to remind people that the presentation will be displayed on Lake Forest TV, channel 17 and 19, also on our local website, and also the City of Lake Forest website. So with that, I thank you for your participation and have a good evening.